thank you to all of you for being here for this summer school. It's really exciting to see such robust participation, particularly for a virtual summer school. And it's an honor to be here with all of you. I think, I at least as I'm hearing some of the introductions, I think I'm one of the few Americans in the room. So it's really a pleasure to be here to learn from all of you and to learn alongside all of you. And so with no further ado, I'm very excited to introduce Professor Ewen Speed, who actually has been really instrumental to my own learning about populism and medical populism in particular. So this is a real thrill to get to introduce him. So with no further ado, Ewen Speed is a professor of medical sociology in the School of Health and Social Care at the University of Essex. He has research interests in health policy, particularly in the context of the National Health Service of the United Kingdom. He's also interested in critical approaches to understanding engagement and involvement in healthcare, and in critical approaches to psychology and psychiatry. Professor Speed has published on topics such as involvement in health and social care, critical mental health studies, and the topics of medical populism in relation to health policy, which is what we'll hear a bit more from him today on. He is a trustee in the Foundation for the Sociology of Health and Illness. Professor Speed is currently an associate editor for the journal Critical Public Health, and he is also a member of the National Institute of Health Research East of England Applied Research Collaboration, contributing directly to the inclusive involvement in research for practice-led health and social care theme and its implementation lead for this theme. So with that, I'd like to turn things over to Professor Speed to take it away for our lecture today.
Thanks very much, Caitlin. I'm going to try and share my screen. Hello, everybody. Okay, this is taking me back to the online teaching in lockdown. Okay, can everybody see my PowerPoint? Yeah. So I'm going to talk today about this topic: populism as political performativity, implications for policy. And I'm not, well, as a qualifier before we start, I'm not that interested in trying to sort out whether populism is ideology or whether it's thin ideology thing. I'm not really interested in those debates. I'm much more interested in the ways in which populism can be used within the political context, and how the performativity of populism is used by politicians to accomplish certain ends. I've got an example which is based on a book chapter that we had published recently that draws on material from the English NHS, which looks at the way in which the Secretary of State for Health at that time, politician Jeremy Hunt, who's now the Chancellor of the Exchequer, mobilised a whole source of populist tropes to accomplish a set outcome. So I'm going to go through a little bit of background, just setting that up, and then it's an empirical case where I go through some of the things that happened in the context of the UK, just in relation to how that idea of populism as a form of political performativity played out. Okay, why is it not there? So, I mean, I'm sure nobody here has not looked at some of this literature and come across this, these sorts of criteria. When we talk about populism, we tend to be talking about core components such as the people juxtaposed against an elite, however that elite might be characterized, and mobilized or not mobilized for or against the idea of the general will, the capacity of people to join together to enforce common interests. So I want to take an approach to populism which doesn't regard these things as being concrete, immutable rules, but a couple of people have already mentioned work of people like the Plough and Mouffe, and that's the context that I come at populism from. It's really taking these sorts of ideas around the people, the elite, the general will, and regarding them as a political grammar for setting out the rules of how populism works. So the people, the elite, the general will, that all sets out, if you like, the framework within which populism tends to be discussed and mobilized and utilized by politicians. But I think we often tend to see populism being talked, and I've written about it myself, being talked about and written about in the context of right-wing political forces. It's also, you know, populism is neither right nor left-wing, it can be either. But I'm not really interested in that side of it. I think there's much more to be learned, or I'm much more interested in learning from sort of the mundane operation of populism. So what happens when populism is sort of played out, not within those extremes, but perhaps more through sort of everyday political discourse. What are the ways in which populism might be seen to operate and be used by politicians? So from that, I sort of take a lead from Leclerc, 2005, who argues that populism is predicated upon a set of political discursive practices which construct a particular subject, contingent upon the creation of a divided social space into those two camps, which in turn are predicated upon the creation of a chain of equivalence between a series of social demands. So really that's what I'm interested in terms of how I think populism works, and what's interesting to look at in terms of populism is how it affects the social demands that people then make through these populist appeals, what processes it follows in terms of division, in terms of society, and what sorts of chains of equivalence we might see in relation to those divisions. But this will all become elaborated through the empirical example that I look at in terms of the UK or the English case. I think Gideon is one of the speakers within the core. I think he's on later tonight, Gideon Lasko, who's done a lot of really interesting stuff in terms of specific thinking and research around medical populism. Gideon Lasko and Curato define medical populism as a political style that constructs antagonistic relations between the people whose lives have been put at risk by the establishment. So again, we still see this reliance on the people as a central characteristic within how we're making sense of populism. I think there's something really interesting going on in terms of populism as it applies to health and healthcare, in that, well, certainly in the UK, for example, we have the idea of the National Health Service, where it's a universal service, so it's freely available to everybody based on need, not ability to pay. So if you've got a universal service which is not supposed to discriminate, it becomes very interesting to contrast that against the way in which medical populism operates through the NHS, because medical population is fundamentally about a process of discrimination, of sorting people out, antagonistic relations between the people and between the elite. So there's something empirically very interesting to be done in terms of working out how that universal imperative gets contrasted against a medical populist imperative. And we did some research on that, looking at the difference between Obamacare and Trump care in the US. And Trump care was very much a sort of an attempt to limit the availability of what was a more universal service through Obamacare. And so the contradiction, if you like, between a sort of universalist logic and the medical populist logic, which tends to be much more nativist and much more about limiting access and control. There's something empirically very interesting going on there that I have tried to look at. But Lasko and Curato will talk about three separate components for medical populism. So it's characterized by appeals to the people, and looks at ways in which those people might be threatened in terms of sort of public health and safety. There's an emphasis on presenting healthcare issues as a form of crisis through moral panics and folk devils. So we've done some stuff on medical populism in relation to COVID and how the response to COVID played out through sort of moral panics. We've also looked at this in relation to anti-vaccination campaigns. So we did some empirical work looking at the way in which anti-vax campaigns played out in Italy through Lega Nord, and how that was sort of mobilized around a moral panic around vaccination. So it's apparent threats to collective values and interests. And the third component that Lasko and Curato talk about is the presentation of common sense solutions. So this medical populist frame, the people versus an establishment, the idea of a moral panic, and the idea of common sense solutions with political bargaining, these are all crucial in terms of the empirical UK case that I'll present present. So I've already sort of mentioned this a little bit. It's frequently linked to nativism. So the idea that some people are entitled to healthcare, for example, and other people aren't, or that some particular groups in society are more likely to be spreading, communicating disease, for example, all these sorts of things. Authoritarianism, preference for common sense of the people of the elite or expert professional knowledge. That's very much the approach that we see in relation to anti-vaccine campaigns. The idea of a vested sort of professional elite that's acting against the interests of the people. All very much predicated on the idea of distinguishing between the people and the elite, and all very much spending a lot of time and effort demarcating those boundaries, those differences between different social groups. So the populist logic would be that it's the job of government to serve only the people and to ensure that those who are not deemed to be part of that group of the people are more restricted in how they're able to access services and public resources. So if we take that as a populist logic around populism, then populism as a means of organizing health policy becomes instantly problematic, because you are instantly talking about depriving some people of access to healthcare services and healthcare provision. So that's part of the reason that I think I got initially interested in populism in relation to health and healthcare, is that there is that fundamental contradiction at the heart of it, which is something that I find needs to be, illuminated and further teased out. So the implications for medical populism in relation to public health are less elaborated than Lascaux and Parato have done in relation to medical populism. So back in 2018, myself and some colleagues, Pavolini, looked at this in a comparative context, looking at different political regimes across Europe and what that might tell us about the relationship between those different healthcare regimes and populism. And within that analysis, we found three key components: economics, governance, and trust. So, and again, this stuff sort of plays out across the empirical case that I'm going to demonstrate in a minute. In terms of economics, healthcare systems which were better resourced, more well-funded, tended to be more resistant to those populist tropes. Healthcare systems with a well-developed or better developed model of governance within how those healthcare professions were regulated and established and so on and so forth, tended to be much more resistant to populism than those where there was a weaker governance framework within those healthcare professions. The way in which healthcare professions were able to engage with and be heard in terms of the policy process, in terms of that model of governance, also had a positive effect. So the more involved the professions were in the governance and the policy process of the healthcare system, the less likely that populist tropes were going to be effective within that healthcare system. Healthcare systems that were found to be more susceptible, more amenable to the populist type turn in terms of policy tends to be those which are poorly resourced, those with high levels of command and control, new public management style governance, where the government at the centre very much dictated the policy. And these tended to be coupled together with low levels of trust in healthcare providers at a societal level. So again, we're seeing a set of components and frameworks that might help us understand the way in which populism plays out in relation to healthcare. So I'm aware that I've talked about a range of components, but I just want you to bear these in mind as we go through the rest of the lecture today. So in terms of populism, we've got the sort of classic Muda idea about the people, the elite, the general will of the people. Within medical populism, we see this mobilized or articulated in terms of threats to the people, the idea that healthcare needs to be mobilized in a form of crisis, and that the solution to this crisis tend to be predicated upon common sense solutions. And then Pavolini is all talking about it in relation to the economics, the level to which the healthcare service is resourced, the way in which it's managed or governed, and the levels of public trust in that system. So these are the sorts of tropes, the sorts of things that help us, the framework that helps us make sense of how populism works in relation to specifically healthcare. Okay, so that's the sort of populist framework. In terms of what I want to do with that framework, I suppose I want to problematize it a little bit. I want to move away from the idea of having to define or decide whether populism is a form of thin ideology or a thick ideology, or whether it's left thin right-wing ideology appended to a thicker nationalist ideology. I don't think that's the most pressing problem that faces us in trying to understand populism. I think it's much more invidious than that. I think it's much more important that we really identify the work that politicians use populism to do when they mobilize it. And I'm not really interested in, other people can be, and that's fine. For me, I'm not interested in sorting out whether it's thin or thick or any of those sorts of things. I'm just really interested in what politicians are able to do with populism. So the one criticism of Mood is that focus on thin or thick marks a boundary between what counts as real legitimate politics and marginal extreme politics, and sort of this, and I don't think that's a useful characterization. So yeah, that's a reference to the example. Jerry Mahon, 5 years and 45 days in office. He was one of the most unpopular health secretaries, but he's also one of the most longest serving health secretaries in recent in all political history within the UK. So populism, yeah, we need to think about the other ways in which politicians like Hunt are using populism. It's imperative to look at the grammar, what it's used to accomplish, not whether it's thin or thick. And I think, yeah, taking a discursive view, taking this sort of after Leclerc move, populism can be all of those things. It can be thick, it can be thin, it can be economic models, political strategy, nativist folkloric politics. It can be all those different things at different times in different contexts for different people. So I don't think that we're ever discursively we're going to get to a point where we can decide that it is specifically thin or thick or whatever. I think it's much more important for us to think about the performance, the performativity of populism and what that accomplishes for politicians and for policy and for politics and for all of us. Okay, so how do we do that? So a little bit on Leclerc and Mouffe, a little bit on principally thinking about logics of equivalence and difference. So this is sort of the Essex School of Political Discourse Theory, taking borrowing the context from a De Cleen and Glenos paper from 2018, which is really nice. It just sets out very practical sort of 8 or 9 steps that we need to think about when we're thinking about problematizing populism. But within this paper, Logic of Equivalence, which comes from the work of Glynis and Howarth in their Critical Logics 2007 book. There's loads of references that are all at the end of the slide, so don't worry, you can get the references at the end. Logic of equivalence is not necessarily the idea that particular groups are seen to positively have the same interests in common. That's not the equivalence. It's more negative, and that they all feel frustrated and endangered by the elite. So it's a negative line of equivalence, unites them against a common enemy. So we can think about this in relation to populism. Populism is very much about the people against the elite. So we've already got that idea of the common enemy. Populist appeals, couched in the context of finite and limited economic resources available to fund statutory healthcare, often performs as a fiscal crisis. So this is to go back to Lascaux, the idea that it needs to be framed in crisis terms. Work to create equivalences between different actors. between the people. And those people tend to be people whose access to healthcare appears to be under threat from unentitled freeloaders who've not made sufficient contributions. So we can see the way in which this logic of equivalence plays out in relation to healthcare. So if you've got a government that doesn't necessarily have health as a spending priority, then it can in part justify its unwillingness to fund healthcare in the way that population might demand, require, expect, by sort of saying that, well, there's a whole range of threats to the healthcare which are much more about people who shouldn't be accessing the services. And this was the sort of rhetoric and discourses that were played out in relation to UK leaving the EU, the Brexit. All the arguments around Brexit and healthcare very much were about people from the EU coming to the UK and using the NHS, and that was putting the NHS under strain because we didn't have enough money to cover all these people. When actually, if you look at data, the UK was a net exporter of patients to the EU. There was more British people from the UK got healthcare in Europe than the other way around, but you wouldn't know that if you looked at the Brexit debates. So the sorts of things that we see mobilised around these equivalences: welfare chauvinism, immigration control, racism, mistrust in politicians, mistrust in expert professions, and so on and so forth. Particular groups are othered through these processes to create an elite depicted as depriving the sovereign people of their rights, values, prosperity, identity, and voice. So these are the sorts of things that we see being played out in relation to healthcare. Logic of difference, on the other hand, is looking at practices which seek to maintain existing structures, and we look to protect the status quo by actively breaking down those self-same equivalences. Creating division rather than alliances. Social demands identities are managed within logics of difference in ways that do not disturb or modify the dominant practice. And so populism is again used in this context to protect the dominant practice. So again, in the example that I set out looking at Jeremy Hunt in relation to the UK general or junior doctor strikes of 2016, 2017, it was very much about mobilising a populist discourse in order to protect the dominant regime. Healthcare reform in the USA, I've already talked about it a little bit, for example, was, Trump certainly mobilised a set of discourses around socialism and socialist medicine, and used that as a way of pushing his own Trump care, which was ultimately unsuccessful. But it's very interesting to see the way in which these processes are mobilised. Okay. Onto the case, and I want to spend a bit of time on this. I think I've got about half an hour to go through this. So yeah, logical equivalent. Okay, so sorry, just before we do that, logical equivalence and difference enable the enactment of particular social rationalities, and this is really important. This idea of social rationalities, again, this is crucial in terms of how I'm arguing we need to make sense of populism. And Leclau sort of prejudges that concern with thick and thin and all those sorts of things, saying that it's relatively ideological populism's relative ideological simplicity. So it's ideologically quite simple in terms of how we make sense of it. It's emptiness. It should be approached in terms of what processes of simplification and emptying attempt to perform, the social rationality they express. So I want you to really bear this in mind when I talk about the empirical case. What I'm trying to sketch out through the empirical case is the specific social rationality that I argue the particular politician constructed, expressed, in order to accomplish, through a whole series of populist tropes, in order to accomplish a specific end, okay? So the argument is that by focusing on what populism does, on the lines of equivalence and difference it draws in specific circumstances, specific cases, it becomes possible to conceive of populism not as a type of political movement of the right, of the left, of the, whatever it is, but rather as a form of political logic, similar to a set of rules, similar to a set of rules for grammatical syntax, which allows specific type or types of politics to be realized. And that's really what I'm interested in, why I'm here talking today. I'm really interested in that idea of what a populist frame enables politicians to accomplish through policy. So a quote from Howard there: society is understood to be the outcome of a series of political and ideological struggles which involve the drawing of political frontiers and the exercise of power. So that's really what I'm talking about in terms of how populism works. Okay. Just before we do that, a little bit of a note on performativity. When I talk about performativity, I'm talking about how the process of talking about something in a particular way brings it into the world, makes it something in the world. So it's the concern with the power of spoken and written language to affect change in the world. So rather than simply describing the world, language is considered to function as a form of social action. So this is the classic sort of definition of performativity. The way in which the politicians talk about populism and healthcare makes that something in the world, and then becomes something that they act on in the world. So by talking about healthcare professionals or migrants or reproductive rights in certain ways, I'm arguing politicians activate or enable specific ways of talking and thinking and responding towards those practices. So as researchers, I would argue we need to think about what the policymakers might be seeking to accomplish through talking about issues in the way that they do and how they do it. And as such, going back to how we make sense of populism, I think it's best considered as a performative means to an end, rather than a distinct approach to politics per se. Okay, so that's my claim. If you wanted to take issue with that claim, that's great. We can have a discussion about it at the end, but that's what I'm claiming at this point, that populism is best considered as a performative means to an end. Okay. This was the only clip I could find of Jeremy Hunt. It makes him look like a real fool. I don't know. I tried to find a better clip, but I couldn't find one. Or it might just be that I'm being really unkind and I thought this was really funny and thought I'd put it in because it makes him look like an absolute ass. Okay, so this is the case of the UK junior doctors, which happened in around about 2015, 2016. Jeremy Hunt was the Secretary of State for Health at that time. He'd been in post for 5 years, 10 months and 6 days. Now we can compare this against Anna Bevan, who was the founding politician that set up the NHS in the UK in 1948, who was in office for a shorter period of time as Secretary of State for Health than Jeremy Hunt. And Norman Fowler was the previous longest serving Secretary of State for Health, and he was five years, 9 months and 0 days. So my point is that Hunt was a very unpopular Secretary of State for Health, but at the same time, he's one of the most longest serving Secretary of State for Health. So in terms of how he maybe mobilized the sorts of processes and the discourses and the practices around populism and healthcare, he was perhaps maybe one of the most successful health secretaries, despite the fact that he was an unpopular populist. The background to all of this is the UK general election, which happened on the 7th of May 2015, which resulted in a very narrow Conservative majority of 12 MPs. Okay, we'll stop looking at Jeremy Hunt. Okay, so what is the case? The case was prior to the general election, Jeremy Hunt made a statement in the UK House of Commons saying that there was excess mortality in the English NHS because there wasn't a 7-day service in the UK. So that if you went into hospital on a Friday or a Saturday, you were more likely to die than if you went into hospital on a Monday, Tuesday, Wednesday, Thursday, or Friday. Okay. Jeremy Hunt went on the public record and said that you were 15% more likely to die if you were admitted to a hospital on a Sunday than if you were admitted on a Wednesday. This was based on an analysis that he did on a paper that was published in the British Medical Journal, which you can see on the right-hand side, which talked about increased mortality associated with weekend hospital admissions. And these senior researchers were making an argument for expanded 7-day services in the context of the NHS. So, yeah. So the wider background is that in 2003, 2004, the Labour government gave GPs and consultants the right to opt out of what were called out of hours and weekend work. So the health secretary is arguing that you've got a Monday to Friday culture in the UK NHS, which means that patients are getting a worse deal on Friday and Saturday. So we can already see we've got the people being mobilised within this statement. They are the great British public, the patients. We've got the elite, which are GPs and hospital consultants. We've got the general will of the people. The general will of the people is that you don't want to die, have more chance of dying in hospital if you're going on a weekend. You've got the crisis, which is 15% more people more likely to die if you're going on a Sunday. You can see all the sorts of things being played out that I talked about previously. What were the other? Then we've got the crisis. We've got common sense appeals, which is that we need to change. We need to get more. We need to get 7-day service. We need to get more GPs, more consultants working at the weekend. So we can see all these criteria being played out in terms of how Hunt sets this up. Okay, can't see the top. So, okay, can I get rid of that? So within, this is an election year, so within the Conservative Party election manifesto, they made an election commitment to increase spending on the NHS, to provide 7-day-a-week access to your GP and deliver a truly 7-day NHS. So you will now always have access to a free and high-quality health service when you need it most. Okay, so again, we've got this really antagonistic appeal to the people, that these GPs need to be held in check. They need to change what they do and how they do it. They're against our better health interests as patients. So, and this is an extract from the Conservative Party manifesto, where they say the vast majority of hospital staff, this is under section 1.2, the vast majority of hospital staff, including junior doctors and nurses, already work shifts across all 7 days of the week. Consultants can currently opt out of non-emergency work at weekends. So we're seeing very clearly a line of antagonism being drawn towards hospital consultants. Can currently opt out of non-emergency work at weekends and the evenings, which means that some only work weekends and emergencies, or if they choose to, rather than being the norm as for other staff. We then get also told that the average hospital consultant's salary is £118,000 per year. And then we then get told that they also get paid an additional £200 an hour for additional work, which is done at weekends. So we can see very clearly these lines of difference being drawn, and the sort of creation of the idea of these consultants as an elite who are operating against our best interests as members of the public, as patients of the NHS, and getting paid handsomely for it. Okay, so this all happened very quickly. This initially happened within the sort of space of a week. The speech in the House of Commons was followed by the launch of the election manifesto. And then the controversy developed very, very quickly. And there was a debate within the House, and Hunt then increased the number of people. He initially said 6,000. He then changed that to 11,000. So he said that, incredible numbers of people were dying unnecessarily because consultants didn't want to work evenings and weekends. Within the House of Commons and outside the House of Commons, some members of the medical profession, writing in the British Medical Journal, accused the Health Secretary of breaching the Ministerial Code of Conduct by misrepresenting official statistics. He was accused, they said, it appears Mr. Hunt deliberately and knowingly misquoted and misinterpreted the conclusions of a medical research publication in an attempt to mislead other members of Parliament and the UK public. So here we're getting into the sort of whole post-truth idea. It doesn't really matter the veracity of what it is that you're saying, just get it out there, get it on the public record, somebody will report it, somebody will retweet it, so on and so forth. When called to this, Department of Health spokesperson, so a government official from Hunt's ministry, said, there is clear independent clinical evidence of a weekend effect, supported by the paper, supported by NHS England's medical director, Bruce Keogh. Clinical experts have said that it's likely to be the consequence of variable staffing levels, a lack of senior decision makers, and a lack of consistent specialist services. We make no apologies for committing to improve care for patients by addressing these variable outcomes throughout the week. So that sort of cleverly crafted response doesn't necessarily directly address the problem around the 11,000 versus 6,000 figure, but sort of, you know, says, yeah, regardless, there's still variance, there's still variability, and that's something that we need to address and need to sort out. So we're seeing very clearly that the terms of the debate are being laid out here. And again, we've got this idea of the government minister speaking on behalf, operating on behalf of the British people, the patients. So in terms of how this performance is utilised by Hunt and by government, the idea of the 7-day NHS is not necessarily something new in terms of the UK general election. It builds upon previous statements that have been developed at policy level. So there was a 5-year forward view, which was a policy review of the NHS in England in the mid-2010s. And the idea of the 7-day NHS was in that. So that was not something that was new. It wasn't a policy innovation. What is crucial to my argument and crucial to this whole process in terms of understanding it as a piece of performative populism was that the 7-day issue was crucial in terms of a new junior doctor employment contract that was on the table and was being discussed between government and between the British Medical Association and effectively the doctors' trade union. And the old contract, which applied to junior doctors at this time, was that their shift pay rates were standard 7 AM to 7 PM Monday to Friday. What the government wanted to change was they wanted to extend the standard shift pay rates from 7 AM on a Monday to 10 PM on a Saturday. So they wanted to get an additional full day, well, what, 24 longer, 17 hours extra on standard shift pay rates for junior doctors. So my argument would be that this was the whole process that underpinned the excess weekend mortality debate. And Hunt used this around excess mortality as a means of problematizing junior doctors' behaviour. The British Medical Association, the trade union, effectively the doctors opposed this new contract, and junior doctors proposed strike action for the first time in their, I think the first time in their history. So yeah, as I said, the 7-day NHS, the allegations about excess mortality at the weekend were primarily about changing employment conditions. They weren't directly about Jeremy Hunt as Health Secretary having any concern about excess weekend mortality or the morality of unwarranted variation in treatment. So what effectively Hunt did was he hunted around, pardon the pun, for a political strategy that backgrounded his economic argument. He really needed to change the core working hours of junior doctors, but he wanted to do it in such a way that it didn't look like there was an economic imperative for what he was doing. So going back to Leclerc in terms of thinking about the social rationality that Hunt expressed in this example was that there was an indolent medical profession, too lazy to work at the weekend, so there was a self-serving elite. The result of this indolence, this laziness, was that patients, the common people, were more likely to die. So this is unacceptable. Common sense action needs to be taken, legislating for the general will, to ensure professionals provide the same service at weekends as is available during the week. I'm not going to go through that health example because I'm just conscious of time. So in terms of going back to Lascaux and the idea of presenting health as a crisis, in terms of manufacturing a crisis, it's something like government interest plus the public interest equals the general will. And the professional interest does not equal the public interest. So there's a line of equivalence between government and the people, and they're lined up against this medical elite who are not operating in the public interest. The mobilization of the moral imperative undermines professional talk about objections to change in these terms and conditions. So it becomes very difficult for the professions to oppose the change to their terms and conditions because the Health Secretary, Jeremy Hunt, has expressed it in such a way that it's about excess mortality. It's about too many people dying at weekends, even though it isn't. But he's established that as a truth, if you like. And so it becomes very difficult for those junior doctors to say, hold on a minute, we don't want to change our terms and conditions. So then it becomes who's got the public's best interest at heart. So government strategy is to create a logic of equivalence, couch and political practices that construct new frontiers in the name of a principle. And this principle brings with it a whole new set of inclusions and exclusions. So the principle is that professions do not have patients' best interest at heart because more patients are dying at the weekend. The new inclusions that this brings with it then is that the government, not the patients, not the professions, sorry, are best placed to respond to the general will of the people. The government are best placed to hold the professions in check, and the government are best placed to save the lives of the people who are dying because they happen to go into hospital on a Sunday, not on a Wednesday. And the new exclusions are against this professional self-serving elite, who government would argue are leading to, well, you could go as far as killing the common people because they're too lazy to work on a Saturday. So I'm not saying that's what's happened, but I'm saying that that is the sorts of claims it becomes possible to make based on the way in which Hunt has expressed the social rationality around the professions. So the profession strategy, they took a line of difference. They were taking the idea that, well, so there was an interesting paper by Gann et al. In the British Medical Journal who did a national survey just after Hunt had said that there was 10,000, 11,000 excess deaths in the House of Commons, and they identified what they called the Hunt effect, which was that more patients were dying because they didn't want to go into hospital on a weekend. They were waiting until they went in until they could go in on the Monday because they thought, based on what this health secretary said, that the service was better on a Monday. So that was actually making people ill. It was actually potentially leading to excess mortality because people should have gone to hospital sooner than they did. They waited until the Monday and then they were in a worse situation. So the GPs and the medical professions got together and labelled this as the Hunt effect. And it's a counterclaim that it's the government that's killing patients, the medical profession is best placed to represent those patients' best interests. In terms of just trying to get back to, so I guess, a fact-checking element, if we go back to the Fremantle paper, it questions the truth. Was there actually a weekend effect? Did Fremantle and the paper that Hunt cited in the House of Commons right back at the start of the example, did they actually demonstrate a weekend effect? So the Fremantle paper found that people admitted to hospital are less likely to die at weekends. So if you're in the hospital, if you go in the hospital during the week, you're less likely to die at the weekend. There's a higher risk of people dying for those who are admitted at the weekend. Evidence suggests that people who are admitted at the weekend are more likely to die, but this cannot solely be attributed to differences in staffing. It could be that patients admitted at the weekend tend to be sicker. It could be that these numbers relate to higher numbers of out-of-hours admissions, which bring with it different criteria. And the best solution might be to hire more nurses rather than changing junior doctors' working practices. So there is something going on at the weekend, but it's not necessarily because GPs and consultants are not working at the weekend. Okay. So this is the idea, going back to Lascaux, of the performing the crisis. We've got collective identities, we've got lazy professionals, we've got wrong family members, we've got heroic politicians. So they constitute the performance of the crisis as a specific rationality. The creation of a divided social space, government and people versus lazy professionals, creation of a chain of equivalence between a series of social demands, the need for a 7-day NHS to stop people dying at weekends. All these performative aspects reflect the creation of a chain of equivalence, representation of collective identity across government and the people through an empty signifier. The weekend effect is largely made up, it's not based on any veracity, that together constitute the identity of these different groups. Okay, outcome. And again, we can look at the outcome in terms of the people, the crisis, the common sense solution. So in April 2016, so he made his initial claim in the House of Commons in 2015. In April 2016, junior doctors in England took unprecedented strike action amidst high levels of public support. They had massive level of public support when they first went out on strike in April 2016. After all this stuff had played out, the subsequent strike action scheduled for September 2016 was suspended amidst reported declining public support for the strike. In autumn 2016, the government was able to impose the new contract, changing their core working hours from Monday to Friday to Monday to 10 p.m. on Saturday, without the consent of the junior doctors. They were powerless, they weren't able to do anything, they had to accept that new contract. It was imposed upon them. In March 2017, NHS consultants, so not junior doctors, a different group of health professionals, made the decision to vote against an automatic ballot of members with regard to a new consultants contract, preferring to alter individual choice over contractual terms rather than a collective ballot. So my argument would be that through this process of hospital consultants too lazy to work on a Friday and a Saturday, this was what Hunt was looking to accomplish, and he managed to do it. He managed to impose a new contract on junior doctors without their consent, with them unable to do anything about it. And he did that by mobilizing public support against those doctors, because he was able to make the argument that they weren't representing public interest. So to go back to Leclerc, the language of populist discourse is always going to be imprecise and fluctuating, not because of any cognitive failure, but because it tries to operate performatively within a social reality, which is to a large extent heterogeneous and fluctuating. So it's this kind of process that I'm trying to demonstrate through this example of how Hunt did what he did. So I'm not saying that there's a roadmap and there's a framework, but the processes and the ways in which Hunt mobilized popular opinion, public opinion in relation to the issue of the day really demonstrates the way in which the linguistic grammars around populism enabled him to accomplish what it is that he wanted to accomplish. So yeah, imperative to focus not on whether what politicians are doing is populist, but rather on the what and the how of the changes they're making. In conclusion, what does this take us in terms of thinking again back to concerns around populism? Leclerc argues the need to conceive of the people as a political category, not as a datum of the social structure. So the minimal unit of analysis would not be the group, but would be the demand. So looking at the way in which demands are mobilized and are backgrounded through populist appeals, through the performance of populism. What are the sorts of demands that politicians use populism to verbalize, to express, to mobilize, and so on and so on. The unity of the group is simply the result of an aggregation of social demands crystallized and sedimented social practices. So if we look at performativity in relation to populism and the way in which it facilitates the articulation of specific demands, then we need to think about ways in which we might challenge those specific aggregations and specific demands. Process of aggregation presupposes essentially symmetry between the community as a whole and the underdogs, the plebs. There's this contamination of the universality of the populace by the particularity of the prebs and the peculiarity of the people who lives. These are the sorts of things that we need to think about in terms of who are the people, how are they made peculiar, how are those particular group of people identified, what's a particularity, and what did those mobilizations, what sort of demands did they facilitate? So rather than regarding populism and ideology, I'd argue it's much more useful to regard it as a set of practices which policymakers use to mobilize social change. I think it's particularly effective empirically in the context of health and medicine because it can function to create division and opposition to things like universal healthcare or things like healthcare practitioners, who typically are, seen to be operating in the public's best interest. So medical populism really has a lot of political usefulness because it goes against, it enables, or it facilitates the articulation of specific ways in which we might think about healthcare or practitioners in a sort of problematic way in terms of problematizing what they do when actually they tend to be working in our best interests as patients. If we fail to address what policymakers do and accomplish through populism, we risk being unable to call their actions to account. And typo on my last line, populism is ultimately a set of performative practices where the performance of policy is what counts. And I'll stop there. So there's some references at the end for the resources, but I'll stop there and I'll stop sharing. Thank you.
Well, thank you so much, Professor Speed. I will admit, as someone whose background is really in public health rather than political science or international relations, like many of our participants in the summer school, I think that being able to have you walk through some of the arguments of the way that populism is situated and defined in the literature versus the argument that you're making is particularly helpful. And I think too, as someone who's somewhat of an applied scholar, this argument that you make about the performativity of populism to advance other policy goals has been particularly useful. And I think, in some of the work that I've done with colleagues really looking at how populist rhetoric has been used to advance anti-COVID policies, right? Or to kind of create a smokescreen to not put in place evidence-based policies, which we've seen, across the world in many, many contexts on both the right and the left. This way of thinking about populism has been really, really useful. So thank you for that.
Thank you.
So with this, I think, given the time considerations, I think, Sumaya, maybe what we should do is break into discussion groups so that we can come up with some questions and come back, because I want to make sure, I could sit here and talk to Professor Speed all day, but I want to make sure that we really make time and space for all of you as participants in the summer school to be able to pose your questions. So maybe we should shift to that now, and then if we've got time at the end, I'll loop back in.